Good afternoon. I'm Adam Myers of the Health and the Public Interest Program, co-director with Dr. Adrian Fu-Berman, who's also on this Zoom. We're happy to have our students here as well as an outside audience, and we're going to get rolling with a very brief description of the program by me, followed by an introduction of the speakers by Shania Chambers, and then a talk which will go about 45 minutes. During the talk, we ask that the audience keep their mics muted unless they're invited to participate in some way. And then after the talk, we'll start with comments and questions by the students and then by the more general audience. I just want to say that the Health and the Public Interest Program is a program at Georgetown University Graduate School of Arts and Sciences that emphasizes the social determinants of health and the broader spectrum of non-clinical influences on health and healthcare. We can be found on the web if you're interested in a graduate program at happy@georgetown.edu. So without any further ado, I'm going to have Shania Chambers introduce the speakers. It's been an effort to make our dates match up and get them here, but it was a high priority, and I'm super thrilled to have them here as well as the students in the audience. Shania?
Hi, everyone. I just wanted to preface by saying after the presentation, we'll be taking questions from Happy students first, and then we'll be taking questions from others who are also in today's seminar. Also, you can leave questions and comments in the chat, and I'm going to start off with some introductions. So Dr. Andrea Deyrup received her undergraduate from Princeton University in the Department of Ecology and Evolutionary Biology before joining the University of Chicago for her PhD, MD, and residency. She trained in soft tissue pathology with Sharon Weiss at Emory University. Since 2015, Dr. Deyrup's career has focused on medical education. At that time, she joined the faculty of the Duke Pathology Department as course director of the first-year medical school pathology. She served on the Undergraduate Medical Education Council for the Association of Pathology Chairs from 2020 to 22, participated in the 2020 to 2021 Duke Teaching for Equity Fellow Program, and was also a member of the Duke School of Medicine Health Professions Anti-Racism Task Force. She's one of the co-editors of the new Robbins Pathology textbook, Essential Pathology, and the upcoming 11th edition of Robbins and Kumar Basic Pathology. She's actively committed to anti-racism efforts and to improving discussion of health disparities in medical education. Dr. Deyrup's fun fact is that there is a species of beetles with her family name. I don't know if I'm going to say this correctly, but Pachybrachus deyrupi is the species. And she's also a fourth generation PhD. So now we have Dr. Joseph Graves. He received his PhD in environmental, evolutionary, and systematic biology from Wayne State University. His research in the evolutionary genomics of adaptation shapes our understanding of biological aging and bacterial responses to nanomaterials. He has multiple books on the biology of race, including The Emperor's New Clothes, The Race Myth, and Race and Racism with Alan Goodman. He leads programs addressing underrepresentation of minorities in science, and he aids underserved youth in Greensboro via the YMCA Chess program. He has also served on the Racial Reconciliation and Justice Commission and COVID Vaccination Task Force of the Episcopal Diocese of North Carolina. He serves as the science advisor to the Chicago and New Brunswick Theological Seminaries through the AAAS Dialogue of Science, Ethics, and Religion program. Dr. Graves' fun fact is that he is the first of African descent to have earned a PhD in evolutionary biology. He also talks about that more in this recent podcast that I will share with everyone in the chat. But without further ado, here are Dr. Deyrup and Dr. Graves.
All right, thank you very much. We are delighted to be here. Let me just pull up my slides and share screen. There we go. Excellent. Well, I'm glad you're all happy students, or there are a lot of happy students. My students aren't always quite so happy, particularly after an exam. Please go ahead and put comments in the chat. Dr. Graves will be keeping an eye on that. We are delighted to be here with our talk, Race and Medicine, Data or Distraction. So just to give you a little bit of an insight into what we do, I am a pathologist, so I make diagnoses looking through the microscope. Dr. Graves is an evolutionary biologist, and we've been giving versions of this talk across the country and in Canada for about 2 years now. Let me just check the chat, make sure all is good. Okay, excellent. And primarily we are talking to physicians, medical students, but also nurses, allied health professionals, and the lay public. And what we'll be talking about here is about how structural racism is in the fabric, the bones, whatever metaphor you want to use of medicine. Medicine very, very closely embraces a racist view. And so I want you to understand this, even though I know that many of you will go on to do policy or maybe not become physicians, because most of the lay public don't understand to what extent we as physicians look at people through a lens of race and make decisions related to diagnosis as well as treatment based on that. So as was mentioned in the introduction, we do a disclosure here, but we're both involved with the most recent book that came out, Robinson Kumar Basic Pathology. Dr. Graves was a hired consultant for that because it's so critical to bring in a scientific process for this, and as well as I'm involved with essential pathology. So over the next 45 minutes or so, we're going to discuss the impact of systemic racism in health professions curricula, compare and contrast biological and socially defined race, evaluate how disparities arise and how it is linked to the pathophysiology of disease, and we'll describe an approach to addressing health disparities in healthcare education. Again, with the belief that we need to stop teaching this material so that it is not propagated through healthcare. So the first question, and something that medical students don't typically recognize when they first start, and what the lay public doesn't understand, is how does race show up in the curriculum? Why are we even teaching associations with race? So in order to get an idea of this, I took our textbook, which we use to teach at Duke, Robbins Basic Pathology, which is used worldwide. It is one of the most widely used pathology textbooks. And in order to understand the depth and breadth of the problem, I did a search through the electronic book using terms like Caucasian, Hispanic, Asian, whatever. And the reason is that I learned a lot of this race-based medicine when I was a medical student. And so when I see it, I don't recognize it as race-based medicine. It's just another epidemiologic fact, could be useful. So I wanted to know how extensive this was. And gosh, it sure was pretty extensive. So here are more than 35 diseases that we are teaching future physicians are associated with either a higher incidence or worse prognosis based on socially defined race. So let's look at how these actually show up in the textbook. Here we have African Americans with a risk of cardiac amyloidosis. We have the carrier frequency of cystic fibrosis in Caucasians, cholesterol gallstones in Native Americans, and adenocarcinomas of the lung that have a typical mutation in epidermal growth factor receptor seen with a variation based on socially defined race in whites and Asians. Now, first, let's set aside the outdated terminology because that should be easy enough to fix. That's a simple find and replace, although it's actually more sophisticated than that. Let's remember that when these sentences were written, they were written with the best of intentions. They were written with the idea that these epidemiologic data would help future physicians to develop a broad yet focused differential diagnosis, to order and interpret the appropriate laboratory tests, and ultimately to design optimal therapy for their patients. So we could say that these sentences were written with the best of intentions. But as we all know, particularly when we're looking at anti-racism work, it's not enough to simply say, well, I had good intentions. You have to ask, are you causing harm? So are we causing harm? I believe that we are. And there are 3 areas I'd like to address. The first of these is one I call buzzword bingo. So we take very motivated, very bright students, and we teach them simple word associations like white, cystic fibrosis, black, sickle cell disease. And then we reinforce this again and again through quiz questions, test questions, clinical vignettes. We have our board exams, and we have the test prep for the boards. So let's take a look here at some of that test prep material. This comes from a website called crashingresident.com. It was published in 2015, so a scant 8 years ago. And in this, the author was suggesting that for students who are taking the first exam in their board series to become physicians, that the best advice he had for them was to be as racist as possible, that there were certain diseases that Black people get, that white people get, that Jewish people get, and also, Asians, and the fact that South Americans and Mexicans have parasites, right? So this is what our students are learning so they can do well on their boards. Now, you may be thinking, this can't be true. Why are we using these associations? Well, we can't actually look at the board questions themselves. Those are protected, but we can do something which is very similar. The next best thing. So there is a test resource called UWorld. It is used by 400,000 people every year, 250,000 of them in healthcare. And what these two researchers did, Rip and Braun, in 2017, was they bought a membership to UWorld, and they looked at the 2,100 plus questions that were in that database. And what they were specifically looking was whether race or ethnicity was mentioned in the cases. So not only did they notate whether, what the particular race or ethnicity was, but they also categorized these as whether they were descriptive, like the person just happened to be white or Black, had nothing to do with the question, or whether it was central, that by knowing that individual's socially defined race or ethnicity was necessary in order to get to the correct answer. So you can see their data here. Let's focus on this first group, white or Caucasian. You can see about 93% of the time, if someone is described as white or Caucasian, it's completely irrelevant to the question. They just happen to be white and they happen to have, a subdural hematoma. And about 7% of the time, it was essential to know that person was white. And so cases that you would see this for would be something like perhaps cystic fibrosis, coronary artery disease, which in this subset, they only linked with this population as if Blacks, Asians, Hispanics, Native Americans didn't have myocardial infarctions. So as you can see here, about 407 times Caucasians or whites were used in the STEM, and that accounts for about 86% of the time that some race or ethnicity was mentioned. Now, one of the things that's problematic about this is that when you consider the actual prevalence of this group, or the proportion in America based on the 2020 census, you can see that's about 62%. So what we would call this here would be centering whiteness. So we have a 25% increase with this focus, as if most people are white and their diseases are more important. While that is somewhat problematic, I think even more challenging is when we look at our Native American category here, where you can see that if a Native American shows up in your test question, that person's not there because they were in a car accident or brushed up against poison ivy. They are there because they are Native American and they have severe combined immunity deficiency or cholesterol gallstones or lactase deficiency. So this suggests that we don't see them in their full complexity, just as stereotypical tropes associated with a particular disease. Now, you may be saying, okay, I get this, but these are just medical students in the first 1 to 2 years of class. And surely when they get out on the wards and they become residents and attendings, they'll learn that all of this, association with race is nonsense. Any person can get any disease. And I would just counter that by saying there are things that I learned 20 plus years ago as a medical student at the University of Chicago using Robbins pathology that I did not learn were false until I started really looking at race in medicine. Now, the next question that we have to ask of our future physicians and of ourselves is there a way race-based medicine is causing patient harm? Because that is our mandate. First, do no harm. And again, I say, yeah, I think we're causing patient harm. So imagine you have a young Navajo woman. She presents to an acute care clinic. She's got right upper quadrant pain right here in the upper part of the belly. And the physician looks at her and says, oh, she's Native American. It's got to be gallstones. That's where gallstones show up. Well, it could be gallstones, but it could also be acute appendicitis or an ectopic pregnancy, either of which can kill the patient. Now, again, you may be saying, you know what, this doesn't happen. I've been in the emergency room. They have checks and balances. They have algorithms. That's how that works. We're not going to make that mistake. So here is an account from the literature. Dr. Graves actually just shared another one with me. This is not something unique or unusual, where we have a misdiagnosis based on race. So this is a story from the misuse of race in medical diagnosis. The author recounts a story of a childhood friend who wasn't diagnosed with cystic fibrosis until she was 8 years old. Now, to put that into context, most children are going to be diagnosed within a month of birth, right? So we do a neonatal heel stick to look. We assess to see if they have elevated sodium levels. So we're going to make this diagnosis very early, and this is important because adequate treatment is going to improve health as well as longevity. But this child presented again and again and again with symptoms suggestive of cystic fibrosis. And in fact, the diagnosis was only made by a clinician who literally could not see the color of her skin. It was a radiologist who looked at the chest film and said, who's the kid with cystic fibrosis? So yes, I think we can be causing, and we are causing, patient harm. So finally, we have to ask, is there a way we're causing harm to our society, right? So is there a way we are lifting one population up and pushing another one down? Are we saying this population is healthier, whereas this one's got bad genes, risky behaviors, they're non-compliant, they don't take their meds? Are we setting up some sort of hierarchy? So to make that easier for you to visualize, I'm going to redline for you all of the diseases in the 10th edition of Robbins' Basic Pathology that are associated with African Americans or African descent. And by comparison, here are the ones associated with European Americans or European descent. So what we're talking about here is race. So let's turn this over to Dr. Graves to discuss what exactly is race.
Thank you, Dr. Deyrup. So in modern biology, races are defined by two criteria: the amount of genetic variation within compared to that between groups, and whether any group within a species can be considered a phylogenetically or evolutionarily unique lineage. Now, it's long been known that in humans, that there is more variability within the so-called races than between them. Now, this is not to mean that we do not have geographically based genetic and physical differences, because we certainly do. But if you take any two individuals on the planet drawn at random, they share 99.9% of their genome in common. Furthermore, if you chose two Africans at random, and one African and one European at random, it would turn out that the African and the European would share more of their genome in common, simply because the greatest amount of genetic variability on our planet is found on the continent of Africa. Next slide, please. Now, what this means is that our species, anatomically modern humans, does not have biological races. Now, what we have instead are socially constructed or socially defined races, which arbitrarily utilize aspects of morphology, geography, culture, language, religion, but only do so in the service of social dominance hierarchies. Now, this is why Alan Goodman and I named our last book Racism, Not Race, because it makes the point that our socially defined racial groups are the result of a social, cultural, historical process, as opposed to being an objective measurement of the apportionment of human biological variation. Now, this fact is gaining more recognition. For example, Merrill's 2017 Introduction to Epidemiology stated, quote, race is a socially constructed variable based on the idea that some human populations are distinct from others according to external physical characteristics or places of origin. But they went on to say that racial or ethnic variations in health-related states or events are explained primarily by exposure or vulnerability to behavioral, psychosocial, material, or environmental risk factors and resources. Note that they do not say that these differences in health-related states are primarily due to genetics. Now, I want to underscore this because I oftentimes people don't hear what I just said. or hear it differently from what I meant. Clearly, there is geographically based genetic variation within the human species. However, those genetic variants do not by themselves, okay, cause the variations we see in health-related states in socially defined racial groups. Next slide. Now, and this can be illustrated by understanding how we use these socially defined groups in with regard to classification of people. So, for example, white, person having origins in any of the original peoples of Europe, the Middle East, or North Africa. But the definition does not answer how much. In other words, how much of that origin or ancestry does one have to remain in the white category? Black or African American, person having origins in any of the Black racial groups of Africa. Once again, we're left with this question of how much, particularly when you understand that Africans have the greatest amount of genetic variability compared to the rest of the world. American Indian or Alaska Native, person having origins in any of the original peoples of North and South America, including Central America, but critically, who maintains tribal affiliation or community attachment. So according to this definition, a person who, with that ancestry who simply no longer hangs out with the tribe is no longer an American Indian or Alaska Native. Asian, a person having origins of any of the original peoples of the Far East, Southeast Asia, or the Indian subcontinent. And then they give a whole list of countries. So you should be able to see right away the difficulty with using this as a useful biomedical or medical category, because you're talking about a huge group of people across a huge swath of geography. And similarly to the other definitions, they don't tell you exactly how much of that ancestry you have to remain in this category. Finally, Native Hawaiian or other Pacific Islander, person having origins of many of the original peoples of Hawaii, Guam, Samoa, and other Pacific Islands. And once again, we are left with this question of exactly how much one has to remain in those categories. Dr. Deyrup.
All right, well, thank you very much, Dr. Graves. Well, this sounds to me like we're talking about geography, right? So we have Africa, we have Asia. Let's take a look at some geography. So this is a map showing the distribution of a variety of diseases. So these diseases are referred to as hemoglobinopathies. They have to do with mutations in the gene that encodes hemoglobin. And you can see that we have a variety of them. We have one called thalassemia, which is shown here in green. HBS is hemoglobin S. That's what we see in sickle cell disease. Hemoglobin C is what we see in hemoglobin C disease, et cetera. And as you look at this, there are several interesting observations that you can make. First of all, these hemoglobinopathies developed and were propagated, became prevalent because they offer protection against malaria. And so what we are seeing here is really a map that shows us where malaria is prevalent. So if we look at this map, you can see here we have green, we have thalassemia. Well, we can't say thalassemia is seen in Asians because it's seen in some Asians, but not in others. We also see it in the Middle East as well as Southern Europe and Africa. So it's really not tremendously useful to refer to populations as more commonly having thalassemia, for example. And then let's look at our hemoglobin S. So this is sickle cell disease. And in this country, this is known as the African American disease. This is what we think about. And you can see here with this orange that, yes, we do see a significant area where we have hemoglobin S alleles in sub-Saharan Africa, but we also see it in Southern Europe as well as parts of the Middle East and India. So what this sort of, I think the way to conceptualize this best is that if we look at this area here where we have a white area in Northern Africa, you can see there aren't any hemoglobinopathies. And you may wonder, well, what is it about this race of people here, this group, this population, that they don't need some sort of hemoglobinopathy to protect themselves against malaria? Well, actually, this white area is where the Sahara Desert is. So no water, no mosquitoes, no malaria, no hemoglobinopathies. So what we're seeing is that is the geography, it is the pathogen which is driving distribution, not some sort of socially defined race. Now, the other point to make here is that while we look at this and it looks, pretty good, and you could say, well, gosh, I guess if I met someone from Russia or Japan, they wouldn't have any hemoglobinopathies. We know that because of globalization and patterns of migration, that basically any person on this planet can be susceptible to any disease. So let's take a closer look here at Africa. We can see here we have an extensive area with hemoglobin S, as well here in Western Africa, a little hemoglobin C. And if we were to compare that to a map showing the origin of enslaved people in the history of our country, you could see that we would expect to have a fairly significant component of hemoglobin S and as well a component of hemoglobin C. And even if you knew nothing about modern America and you made that guess, you would be right. So here's just one study from the Howard University Sickle Cell Screening Clinic. And you can see that most individuals are wild type for hemoglobin A. We have about 10% who have hemoglobin S and a smaller percent with hemoglobin C. So you may be thinking, okay, well, we can't use socially defined race like African or African descent, but if we can think of this and we can identify people who are the descendants of this group, maybe we could make some sort of inference. But phenotype is not genotype. You cannot tell by looking at someone what their genotype is. And this becomes important when we start considering facts like the different prevalence of these diseases. So as you can see from this table, the prevalence of sickle cell trait in the United States is about 8 to 10%. But we can see in parts of Africa, it can be as high as 15 to 28%. And the reason for this is because we have ongoing pressure from malaria in Africa, but not in the United States. So you don't know if you see a person, whether they have just come from an area of Africa with an increased risk of malaria, they have a very high risk of sickle cell trait, or whether they're from an area where there isn't any sickle cell. So you cannot tell by their phenotype. This gets very complicated as well because a rising share of the US Black population is foreign born. So you cannot look at someone and extrapolate what their history is. And then we're going to bring in the issue of population admixture. So that's a very interesting topic. I'm going to turn that over to Dr. Graves.
Thank you again, Dr. Deyrup. So when we look at the ancestry of persons who are socially defined as African American, it turns out that the average ancestry, European ancestry in African Americans is around 16%. But that can change dramatically by the geographic region of the United States. For example, in South Carolina, the average European ancestry in African Americans is very low. But in West Virginia, it's on the order of 30% European ancestry. And similarly, in states like Washington and Kansas, the amount of European ancestry in African Americans is very high. Next slide. Now, when we look at Latin Americans, they represent a triad mixture of European, African, and Amerindian or Native American ancestry. And that can vary dramatically. Next slide. So, for example, in Puerto Rico, individuals are on average 72% European, 16% Amerindian, and 12% African. But in Mexico, individuals are only 46% European, 51% Amerindian, and only about 3% African. Now, in Peru, individuals tend to be 80% Amerindian and only 18% European and 2% African. But within Peru, there are communities that are Afro-Peruvians who are essentially 80% African. Similarly, in Colombia, the national averages are 64% European, 29% Amerindian, and about 7% African. But within the country, depending upon where you are, next slide, you can see different admixture percentages. For example, in the city of Medellin, the admixture percentage looks very much like that of the national average. However, in the neighboring state of Chocó, which was a site of plantation agriculture and saw the importation of a number of enslaved Africans, you see that their admixture percentage is about 80% African, a much smaller percent European than you would see in African Americans, and a much higher percentage of Native American than you would see in African Americans. Now, of course, to people living in Colombia, they see themselves as Colombian. They would only know about American racial classifications if they came to the United States. And so this again underscores that these racial categories are socially defined, not in fact measurements of individuals' genetic ancestry. Dr. Deyrup.
All right. Well, thank you very much for that, Dr. Graves. So I hope that what we can agree on after all of this is that race is not a biologically useful construct. So why are there racial disparities in health and disease? So there are a number of what we would consider intrinsic causes of disparities. These would be genetic causes. So examples of this would be selection advantage. So for what we talked about with the hemoglobinopathies. And this is typically going to be related to geography because it is some sort of ancient or current pathogen. We can also have a founder effect or a population bottleneck. So this is something where we would see severe combined immunodeficiency in the Jicarilla Apache and the Navajo Nation. But this is due to the genocide that occurred earlier in the history of our country, affecting a particular population, not the race that we use, which is American Indian. So it's not all American Indian, it is a subset. And then we have endogamy, which means marriage within, but more specifically, breeding within one's particular group, which may be due to religion or caste or geography. But again, these are populations, not races. So as you're going forth in your career, you're going to see that lots of money and energy is being spent trying to tease out these intrinsic, these genetic causes of disparities. And I would just like you to remember this quote from 2003. This is from the New England Journal of Medicine, a very highly regarded journal. And what Cooper and colleagues said is to remember that variation is continuous and discordant with race. Systematic variation according to continent is very limited, and there is no evidence that the units of interest for medical genetics correspond to what we call races. So all of this money and effort is not answering the real issue of why there are differences between these populations. And there are differences. Do not think that we're talking about splitting hairs here. So we look here, this is from the CDC, looking at maternal deaths. You can see that African Americans have 40.8 deaths per 100,000 births, elevated levels as well as in our American Indians and Alaskan Natives, compared to about 12.7 in European American women. This is, if you look at pretty much any type of cancer in the United States, you will see that the population with the highest death rate from that cancer is going to be African Americans. So you can see here, just looking at colon and rectum, we can see our Black males are up here at the top, corpus, uterine corpus and cervix, again, Black females at the top. And then if we look at very complex diseases with our multifactorial, such as hypertension and diabetes. This is a paper looking at what they call a heat map, showing the prevalence in these two populations, red showing a higher prevalence, blue a lower prevalence. And you would be excused for glancing at this image and thinking that hypertension and diabetes are much worse in whites than in Blacks because of the extensiveness of the red. The reason for this, however, is that they skewed their scale. So you must always pay attention to this. This is the range that they're looking at in whites compared to what they're looking at in Blacks. And if we use the same scale, this is what it looks like. So clearly there are massive health disparities. So what is causing these disparities if it's not these intrinsic causes? It is the extrinsic causes, right, which are very closely aligned with socially defined race. So poverty, access to care, living conditions, food access, neighborhood, exposure to toxins, stress, availability of health insurance, and all of these will be affected by individual, institutional, and systemic racism. Now, I'm going to take a moment to focus on those last three. They've entered the popular media, but it's always good to be on the same page. This is a figure from the website dismantlingracism.org, which I highly recommend. So this is looking at the three expressions of racism. So the first of these is what I, as a white presenting person, assumed was what I thought about when I thought about racism. It was personal racism, individual acts, what they refer to often as bad apples. What I think most of America, or much of America, realized perhaps for the first time with the murder of George Floyd and the really national look at what is going on for people who have been very insulated from this, is that institutional and cultural racism permeate all of our existence. So institutional racism is the policies and practices of institutions like universities and hospitals that include and serve and financially resource European Americans at the expense of other groups. An example of this is there's a genetic disease called phenylketonuria, and it must be diagnosed at birth or children will suffer tremendous loss of intellectual ability and have other cognitive issues. When they first started screening for this disease in that first clinic, they said, you know, let's only do white kids because Black kids don't get this, which is not true, but it shows that bias. And then cultural or systemic racism are the beliefs, values, and norms of a society or government that, again, is going to uplift, validate, protect our European Americans at the expense of other populations. And the clearest example of this is access to healthcare, because our society does not believe that everybody deserves access to healthcare. And you all know from personal and professional experience that this is what really is causing health disparities in this country. So let's take a look at this in the context of medicine. So here we have some of these extrinsic causes. This is a really useful exercise I recommend that you undergo whenever you see an association with race and some particular health issue. So this is a statement from Up to Date, which is a resource used by physicians. And in this quotation, they're referring to two studies listed below. There are two types of hysterectomy that a female can undergo. One is an open hysterectomy, so there's an abdominal incision, fairly large. It takes a while to heal from this, so the abdominal muscles are cut. One can't lift heavy objects. It can be very painful. It takes a while to recover. Compare this to a minimally invasive technique, which can be done either laparoscopically or a robot assist or a transvaginal hysterectomy, which is much, much easier to recover from, and people tend to do very well with that. And what these two studies found is that they looked at women who were eligible for either type of approach, that if they were Black, Hispanic, or publicly insured, they were less likely to receive these minimally invasive techniques compared to white women. And the factors involved would be systemic racism because of the link with public insurance, institutional racism because the hospitals that treated these particular populations had fewer surgeons who were skilled in minimally invasive techniques, and then poverty, education, access to care, health insurance, et cetera, all come into play. And then if we look at this quote from the 10th edition of Robbins-Based Pathology talking about high blood pressure and African Americans, we would say that all of these come into play. I don't know how many of you are familiar with the idea of the slavery gene, which got significant airplay on Oprah with Dr. Oz. There is no slavery gene. It's all of this which is contributing to the pathologic effects of high blood pressure in African Americans. So what do we do next, right? So you're the generation that needs to learn this appropriately and accurately and to infuse your future work with this understanding. So we're going to talk about 4 things here: terminology, mindful analysis of the material, inclusivity, and context. So let's begin with use of terms. So this comes from the section that Dr. Graves and I wrote for the new edition of Robbins. In that textbook, we removed all of the archaic anthropological terms. Predominantly the one used is Caucasian. I would urge all of you to abandon this term. It is a pseudoscientific term that came into use in the 18th century during the time of colonial exploitation, enslavement, and genocide. And this term, just to put it into context, was used at the same time as terms like Mongolian and Ethiopian, which we don't use now, although believe it or not, you can still do a PubMed search and find this in the literature. We also removed all terms related to skin pigmentation. All right, so we typically refer to people as whites or blacks. This is problematic for a number of reasons. One is if you use whites and blacks, then you've also got yellows, browns, and reds, and nobody wants to do that. The next issue is that first, these aren't accurate. White people aren't white. Black people aren't black. So they are bringing in this false association. But the false association is pernicious because there are actually cultural and symbolic associations. White with purity and innocence, black with evil and bad. So we just don't need to use these terms. The terms that we use are based on ancestry and socially defined race. So ancestry will refer to someone as being of European descent or African descent. And this is something that we'll see for our single gene diseases like cystic fibrosis and sickle cell disease. But we're also very careful when we do this because typically it's not going to be just African descent. When we think about sickle cell, as I mentioned earlier, we see this in Southern Europe, the Middle East, and parts of India. So we don't want to set up this buzzword bingo, this word association. We want to emphasize in our textbook that when we refer to sickle cell disease, it is because of protection against malaria, areas associated with malaria, which include Africa, Southern Europe, Middle East, et cetera. So we want to be sure we're clear about that. And then we use socially defined race for our complex diseases. So we're all familiar with the term African American, Asian American. European American isn't used very often, but it's the appropriate parallel structure. We're not going to say African American, Asian American, and Caucasian, right? So European American is what it is. And these will be our complex diseases, which are the vast majority of diseases that affect humans. There are very, very few single gene diseases. Most of these diseases are going to have a genes times environment contribution. In fact, all these diseases do. And the environment is often going to be more of a contributor to the disease than genetics. So then just a word about ethnicity in the United States. We often will dichotomize ethnicity as Hispanic and non-Hispanic. Let's look at that term. Hispanic is going to refer to populations that speak Spanish. So this means that our Latin American countries like Brazil, Guyana, and Suriname will be excluded, but we'll bring in the Spaniards from Spain, which, as you all know, is going to be a very different population than someone who is from Mexico. There are some terms that are used. So Latino, Spanish is a gendered language. So Latino for male, Latina, the term Latine, which is gender neutral, or Latinx is also used. Because these terms are in flux and are not universally used by all individuals from this area, we use the term individuals from Latin America in the United States. So with that out of the way, what you need to do is to really question the data. Whenever you see an association with race, is to ask, is it true, and why is this coming about? What is the cause of this? So let's work through this exercise, looking at something which is probably something you haven't thought a lot about. So this is a sentence from Robbins' 10th edition about keloids. So keloids, for most of us, when we get a surgery or we have a cut, it heals up very nicely. There's a proportion of the population that will develop these very exuberant scars that can be very disfiguring. And in the 10th edition, it refers to an association with African descent. Now, one of the things that I did for my students after I generated that list of all of these diseases was I did a deep dive into the literature for each of them to understand for myself and to share with my students what the issues were. So because I had done that, I recommended to the author of that chapter that this section be removed. And his terse reply was, but this is what it says and up to date. UpToDate being that resource I mentioned that many physicians use. Well, because I generated this document for my students, I had read what it said in UpToDate about keloids. And in fact, not only had I read UpToDate, I'd also read this reference number 5, as well as about another 30 papers on keloids. This is what reference number 5 says, Robles and Berg. One of their comments, we did actually see the 16% in the Robles and Berg paper, but a statistic that really caught my eye was that it said that the risk of developing keloids is about 15 times higher in dark-skinned individuals compared with whites. Now, 15 times higher is a big number, and I don't know how good y'all are at statistics, but typically a 15-fold difference is statistically significant. Now, it may or may not be clinically significant depending on, what that number is. If it's 0.00001, it's not relevant, but, it could be important. Now, the reason this 15 times caught my eye was not only because it was such a big number, but because I saw it again and again and again. Here are some of those papers. I believe Brissett was the index paper. That was the earliest reference to this 15-fold increase that I'd seen. Let's see what Brissett had to say in 2001. So this is where that statement comes from. In a review of 175 cases of keloids from various races, the authors found that keloids were 15 times more likely to occur in darker-skinned individuals. Well, let's look at this paper from Al-Hadi and Savanathara and see what they actually found. This is from their 1969 paper. The research was done in Malaysia, which is why these are the groups they're looking at. And what you can see is that the relatively fair-skinned Chinese appear to be slightly more prone to keloids than the dark-skinned Indians and Malays. Now, I did the math because they did not. 2.4 to 3.3 is very different from 15. Furthermore, the arrow is pointing in the wrong direction. So clearly, there is some lack of truth being propagated in literature. So let's return back to the statement that had my editor so convinced that we needed to include this. Here we can see that keloids have been reported in 5 to 16% of individuals of Hispanic and African ancestry. So what I did was I went back again and again and again through the literature. And most people would refer to this number and they would refer to a previous article that wasn't doing the actual research. It was a review article or whatever. But I finally found this number. May 17th, 1931. So this is an article from the French literature. So if you're having difficulty reading it, it may be because the article is old and the contrast is a little low. Also, it is in French. So this is the proceedings of a dermatologic meeting in Strasbourg. And at this meeting, the presenter, Monsieur Lespin from Brussels, gave a talk on tattoos and keloids in Negroes of the Congo. And after he finished, as so often happens at scientific meetings, as someone stood up and instead of asking a question, presented his own data. This is Monsieur Staub from Leopoldville, Belgian Congo. And what he did was he said, I really enjoyed your talk, but let me tell you about my research. I was in the Belgian Congo, and I had the opportunity to look at 1,205 Black adult workers between the ages of 16 and 50, and I examined all of them to see if they had keloids. Now, let's just pause and recognize the colonial exploitation of this setup, okay? So this is a white Belgian who is examining 1,205 adult Black workers in the colony. But what he found was that, in fact, 16% of them had keloids. That number is the one that came all the way down through 1931 to 2021 and up to date. Now, this is problematic for a number of reasons. So I've learned a lot from Dr. Graves on this. What you can do with these data is you can say, 16% of the adult Black male workers in the Congo have keloids. But you can't extrapolate to Africans or people of African descent. Remember, more genetic variability in Africa than anywhere else. You can only speak about the population you have examined. Now, this is problematic enough that this generalized comment has been made. What I find even worse is that on that very same day in Strasbourg, at that very same meeting, another presentation was given. This was by Professor Negli from Bern, Switzerland. He too was interested in keloids, but he did not have a research site in the Congo. So he just looked at adults and children in Switzerland. And what he found after looking at 834 was that 13.3% of them had keloids. Now, the reason I find this problematic is that these two numbers are not tremendously different. Speaking as a clinician, I would say this has minimal or zero clinical significance. But the number that comes down to us through 90 years it's not the understanding, pretty much anyone can get a keloid. We don't, anyone susceptible to it. Take a good family history, examine the patient. What we see is Black people get these horrible disfiguring scars. Isn't that terrible? So when I put all this information together and presented this to the editor, this is what we now say in the textbook. Keloid formation seems to be an individual predisposition. Now, this may seem to you like, this is just, it's such a trivial matter. It's not a cancer. People don't die from it. It actually does have impact. So in September of last year, I got an email from someone at the California Department of Public Health, because in addition to generating this document, I've also put together a series of videos, and someone had seen my video on keloids, and I highly recommend this video. I can send you the link. It's on my YouTube channel. And the state of California was making recommendations about Mpox vaccine. We were trying to extend the supply that we had by doing intradermal injections instead of subcutaneous use. And the CDC had recommended that the intradermal injection not be used for people with a history of developing keloid scars. The state of California then went further to emphasize the fact that the incidence of keloid scarring is higher in darker pigmented individuals of African, Hispanic, and possibly Asian descent, which, as you'll notice, is pretty much everybody except white people. And again, we have our 16%. So a physician saw this, emailed them the link to my video, and they reached out to us. Dr. Graves and I had a Zoom meeting with one of their researchers, and 3 days later, this data was gone. Now, this is important because we're talking about a marginalized population that already has got vaccine hesitancy. We need to be sure that we're not affecting our patients. Now, I will tell you that when you begin this sort of data review, where you're trying to find the truth and the falsehood, that as soon as you do this, people are going to say, but what about? So just be ready for this, right? Someone is going to cherry pick some paper and say, but what about this paper? This paper shows that Black people get keloids more than white people. So the problem here is when we look at this, so we have one paper that says 7% of African Americans compared to 0.5% of whites. We have this other paper saying 0.8% of African Americans and 0.1% of whites. We compare that to the 16% from the Congo, the 13.3% from Bern, and you can see these numbers are all over the place. And the reason is you cannot talk about specific populations when the populations themselves are not specific. And that is what Dr. Graves was showing you when he talked about the population admixture. So as you do this work, you got to build a team. You need to bring in as many people with different voices and empower them to speak and be sure to listen. So your team I would recommend starting off with a gentle team and then lean into it to the more challenging members who really are pushing. We need to bring in the students and the trainees. So the generation of students tends to be more advanced in this work, more open to it than the older generations that really have steeped in the tea of race-based medicine for generations. If you were to go to a 65-year-old cardiology attending and talk with him about some of this stuff, he's going to be firmly believing in race-based medicine. We want to be inclusive with our images, and I'm sharing this in a way so you can see what it is that physicians are learning. So typically in a medical school, this would say a 62-year-old Caucasian man. Now, I removed all the race and ethnicity when I became the course director, but you can still see this is someone that you would call a, quote, Caucasian man or woman, probably man. So what we do now is we add in this image with someone with a darker skin type. So we show multiple skin types for this vignette. We're not trying to say this is the same person. We're saying, look, this is what it can look like. This is actually a basal cell carcinoma, which has a classic appearance in lightly pigmented skin. In darker skin, this actually mimics a melanoma. One of these is locally aggressive, excise it and you're done. The other is widely metastatic and can kill you. So it's important for physicians to be able to distinguish these. These are images from the 10th edition of the textbook. And to emphasize what we're seeing here, here are some of the few images that we have that show lesions in darker skin, including the ubiquitous keloids in someone of African descent. So for the current edition, we are showing lesions, much as we do at Duke in our teaching, in multiple skin types. So we have our basal cell carcinoma, we have our keloids here, we have psoriasis here. I don't think this image needs much discussion, and I show this to you just so you understand how prevalent and universal this centering of whiteness is in medicine. So these are the cartoons from the 10th edition of Robbins. For the 11th edition, we've removed this light peach color or pink color. I wonder how much impact it would have if we talked about peach supremacy or pink supremacy instead of white supremacy. What we've done is just to remove all coloration and use just the color of the page. Finally, we want to be sure that we use appropriate terminology and provide context. So this is looking at a particular mutation, which causes an increase in clotting. So patients with this tend to develop blood clots. We can see here in the 10th edition, refer to whites. We don't use this. This is genetics, so we're going to refer to ancestry. But as I mentioned before, we don't want this to be something that obscures what the actual prevalence is of this in the population. We don't want this to be a dog whistle. You know, when the textbook says European ancestry, they mean white. So we emphasize that we can see this in other American groups, largely due to population admixture. And this is particularly important for this disease because while we are mostly concerned about our homozygotes who have 2 copies of this mutation, of this allele, we can also see increased clotting in people who have only 1 copy of this allele, who may look for all the world like they are African American, but coming back to population admixture, this can be one of the genes which is of European origin. So let's finish up just by asking, right, our question, is race in medicine data or distraction? We know that biological race does not exist. But social defined race has a tremendous impact on health disparities, both morbidity, so how sick you are, and mortality, so the death rate. So we don't just pretend that social defined race is non-existent. We have to recognize its impact so that we in public policy, you know, politicians, people who care can make the difference. Here's a list of our references, and we'll take questions now. You can email either of us. We're both on Twitter, and I have a website called pathologycentral.org, which has the keloids video as well as some other videos on race and medicine. With that, I will stop sharing, and we will take questions.
Okay, so now we're going to take some brief questions from happy students first, following the others who are in this seminar. So if any happy students have any questions, feel free to raise your hand and I will pick on you. I guess I have a question first. So I know that social factors like contribute to the kind of healthcare delivery a person receives, but I read an article that studied like how the wealthiest Black moms were more likely to die in childbirth than the poorest white moms. And I was wondering if you would know, like, if you could expand on that and if you would know like why that's the case.
So I will say something briefly, and then I know Dr. Graves will have a lot to say. So I think this is really important, a really important question, because what we think about, of course, is like Serena Williams, right? How could she have had a challenge with her pregnancy when she is a superstar, right? There are reports in the literature of African-American physicians who are, you know, in pain or who have decreased oxygen saturation, who are asking for help and are ignored. And what this is due to, Shania, is racism, okay? So wealth will not protect you. Social position will not protect you. Fame will not protect you from systemic racism. And that's why this is so urgent that we as a country face this, because and Dr. Graves can speak more to this as well, but these social determinants of how, like, the overwhelming impact of 24/7, your entire life racism the stress, the anxiety, what this does to your cortisol levels, this idea of allostatic load or of weathering, it takes a tremendous toll. And particularly at medicine, where we have this interface of a very hierarchical discipline with disempowered patients, regardless of your race. When the doctor comes in, you're lower in the hierarchy. And the fact that we teach all of our medical students race-based medicine, and we live in a systemically racist society. That is what is causing harm. Dr. Graves?
Yeah, I was just going to say the same thing. There's something in sociology called the out of place principle. And that's basically where an individual who is in a socially defined group thought to be inferior has their life lived in a profession where people don't expect to see you. So, I mean, I speak about this in my book, Voice in the Wilderness, and that leads to chronic stress, the, consistent microaggressions. In my case, they used to be macroaggressions, and those things impact your health status. So it's long been known, for example, that African-American physicians who are some of the wealthiest African-Americans actually have chronic hypertension precisely because of the out of place principle. So bottom line is structural racism is real. It impacts how people live and certainly influences how they die.
It's just shocking and painful to me. The difference, a white person walks into a store, strolls around with a backpack and walks out, doesn't buy anything. A black person does. That same dynamic, right, where someone's watching them, not trusting them, thinking negative things about them, is exactly what we see in medicine. And, this is one of the reasons why it's so critical to get more people who are underrepresented in medicine into medicine, because we know that when African-American patients have African-American physicians, they tend to do better, right? I would recommend a very painful book called Under the Skin by Linda Villarosa, which has a number of these narratives about the impact of racism on health. But it's not like you get to walk in and say, I'm Serena Williams and I'm a celebrity, I'm a multimillionaire, so listen to me and treat me with respect. It's so deep, and it's the bones of medicine.
Thank you. And Matt has a question now.
You're muted, Matt.
Hi, thank you. My name is Matt Salmon. I first wanted to say how grateful I am for this presentation. It was incredibly informational, and I'm a child psychiatrist, and I've seen firsthand on numerous occasions the effect that seeing someone treating someone based on race has been really problematic, or even maybe the implicit biases that people carry, or that racism and its impact in medications that are chosen for people based on race, or the diagnoses given to people, which then maybe lands them on a medication that's much more greater than they even need to be on, or has much more risk. And I'm wondering if through the research that you've done, because I would love to get a copy of it if you have information about mental health and the impacts of race in medicine in psychiatry.
I mean, there are some studies of this. I'm not a psychiatrist, but certainly I can send you references to the ones I know about. In the chapter I think 7 of our book on intelligence and personality, my book with Alan Goodman, we talk about particularly differential diagnoses of schizophrenia in persons of African descent. And we, when we look at, the evolutionary and genetic underlying mechanisms of schizophrenia and show that they're not really differentiated between these populations, but African-American patients are more routinely diagnosed as being schizophrenic as opposed to bipolar disorder.
Yeah,
Uh,
thank you.
Yeah, I don't, so my focus is on pathology, and in the you know, it's very interesting. The different chapters are written by different people, and different authors have different attachment to race-based medicine. So despite our efforts, there's still some race-based medicine in the 11th edition, because all the other editors were very attached to race-based medicine. So it was quite a battle to remove what we did. There was not much in the central nervous system part because the pathologist who wrote that didn't put much in. I don't know if you're familiar with Jessica Eisen. She's an African-American psychiatrist who's an activist and has a very powerful voice. So I don't know if she's on Twitter, or you can just Google her. She does public things in publishes in Medium and elsewhere.
Absolutely,
But
yeah.
thank you.
I haven't heard of her, but I definitely want to check her out. Thanks so much.
Do we have questions? Oh, Ella, you can go ahead.
Hi, this actually came to me from one of the comments from Ashley in the chat. I do not experience this as much in Happy, but I guess my question is, how do we work on this in health policy courses where you're learning from like an economic standpoint and they're trying to include, social determinants of health in their modeling or giving people ideas around that. And all of a sudden they're perpetuating way worse ideas. Like, do I go to the professor? Do I do that in my own work? Where do you, I don't know.
Okay, so first let me address what Ashley said. Yes, this absolutely has to be systems change work. Absolutely. This isn't like, oh, we can solve the problem if we just get more Black physicians. We're done. No, absolutely not. How do we create this change, which is your question as well, Ella. So the way that Dr. Graves, there are multiple ways you can do it, right? You can write books, you can write articles. What we are doing, this is the approach I've really chosen. Dr. Graves has multiple other venues in which he does his anti-racism work, but we like to do these grand rounds presentations or these talks because at each one we feel like we start a little fire and it grows, right? So I see this as sort of a grassroots approach, right? And we remain connected with people who have done work. I'm not really sure. It's like we've been asked to advise on a number of different issues, from radiologists saying, "Oh my God, I've just realized all my work is race-based medicine," to a World Tumor Registry that says, "Oh, we want to include ethnicity as one of our data fields," and us explaining why that's a bad idea. So that's our approach. So because I don't have power, I can't create systems change. So I believe in the power of the individual and grassroots. But someone who does, and I've reached out to the National Board of Medical Examiners, looking at board exams for medical students, because that is a part of systems change. So Dr. Graves and I have spoken to them twice about race-based medicine. They're removing race-based medicine from that. So that is systems change. But I see, from what I've seen in my experience, the most powerful work comes from individuals. So that's what I do. As far as, yes, I completely agree. There is so much bad race-based fixes out there, and some of the suggestions are worse than the disease. I think as a student, it's really challenging. The way that I actually got involved in doing this work is a student asked me a question. So I think one of the best approaches is to approach this with curiosity and respect. And I say that as someone who's white presenting, because I understand that people who are white or white presenting will frequently get very defensive around this. So the way the student approached me was, hey, there's a lot of information about race-based association in medicine, and I'm wondering if we could discuss some of the data around this, because there doesn't seem to be a consensus. So we actually, Dr. Graves and I were approached by a student from one of the places where we gave a talk who said, oh my God, I'm being taught all this race-based stuff in genetics. What do I do? So we gave him a couple of approaches, and the professor basically was like, slammed the door, wasn't interested, wasn't opening, wasn't, so I was just like, back off, man. Here are some resources. I can help you to develop your own understanding of it. But if this guy wants to use pseudo-Africanized Ethiopian names to suggest this person has a lower metabolic rate of a particular pharmaceutical, I can't fix that problem. So I would gently go into it. And this is my approach, right? Because I'm actually, I don't find a lot of success with fighting with people, with arguing. I know there are people who love to argue. The other 3 editors of the textbook love that. That is part of what they do. I'm not interested. I know I'm right. Just accept it, right? Just remove this stuff. So understand, and this is maybe very different from what Dr. Graves will say, or certainly what Dr. Eisen will say. They'll be like, it's been 400 years of racism. It's done. I'm not going to sit here and be curious about why this is. So you have to find your own approach while balancing what it is that helps you to feel safe. And it's really up to, Dr. Myers and some of the other, faculty to smooth this path, to do this work. I actually, when I gave this talk at Harvard, I had this guy who was part of the DEI group, and he's like, oh, I don't know what to say because, I don't want to offend this person or that group. I'm like, you are a white male full professor at Harvard. If you can't lean into this work and take a risk, how can we ever expect anyone else to do it? So I think those of us like Dr. Graves and myself are leaning in because we're both full professors. I'm like, go ahead, fire me, right? And I really think we have to do this. We have to support you. We have to provide safe spaces for you. And we have to educate you at the same time we learn from you, because we do learn so much from you.
Yeah. So what I would add to that is that we do have an intellectual obligation to take on, the use of biological race as a proxy variable for social determinants of health. So this is work that, scholars have been engaged in for some time now. And, intellectually, we are winning that battle because we can demonstrate, and have demonstrated over the course of the latter portion of the 20th century, one, what the actual nature of human biological variation is and how it doesn't correspond with the social definitions of race. And then why, for example, when we look at, particularly social economic models, using this proxy variable in place of the actual social determinants, gives you the wrong outcome. So there's an extensive literature on that. And it's now surfacing in, microbiome studies. And I, I'm one of the leaders of NSF Engineering Research Center of Excellence in Microbiomes. And, we're shooting down a lot of those kinds of approaches in microbiome research. So that part is relatively easy. Now, the portion that Dr. Deyrup was talking about with regard to how you do that as a graduate student is an entirely different question. And what I say to my graduate students, in fact, I actually forbid them from getting involved in that research, precisely because that puts a huge target on their back. And do I know about a target on my back? Yeah, read my book. I've been thrown out of some of the best universities in America. So you don't want to do that as a grad student. You want your faculty doing that. You shouldn't be doing that. You should do your work, finish your degree. Okay. And if your goal is, going into the academy, then what you need to do is, achieve tenure. I didn't write my first book, The Emperor's New Clothes, on this topic until I was a tenured professor. And even then, when racists came after me and wanted to sue me, my institution wouldn't defend me. So it is a choice that you will have to make with regard to your life and your career, whether you're really willing to stand up against, systematic racism, and there is a cost. I'd be lying to you if I told you there wasn't a cost, because there is. But, this is work that people of, good ethical and moral fiber have to take up.
Yeah. And I want to make a comment about something I put in the chat, is that so because racism is so baked into science and to healthcare, the problem with this is that there are thousands and thousands and thousands of articles that support a biological idea of race, right? So this is because, you know, you write, you have your paper, you do your research, and the only difference you find is between blacks and whites. So you publish that, right? You don't account for any of the contributing factors. And so when you want to fight racism in science, people are easily going to drop 20 or 30 papers in your lap that say, see, look, there's a difference. There's a biological difference here. And it's because, you know, it's like garbage in, garbage out. I mean, you know, even the terminology, how was race decided? Was it the administrator looked at the person, said that person's black, that one's white? That happens in many, many papers, particularly in the older literature. I would say that nothing that refers to socially defined race older than 20 years ago is even worth looking at. How do you even know how they came up with that? I think a lot of the stuff that's come out since then is also garbage. So that's why we need to look at it and question. So I would, because you care, because you're interested, ask that question. Could you please help me understand this? Or I'm just curious. And maybe that's enough, right, Ella? Maybe that question, you don't need to go out on the limb. You don't have to be out there saying, you know, I'm going to fight this. What you do, you just ask, I'm curious, I want to know more. And if that person says, gosh, you know, I never thought about it, let me read some and get back to you. Maybe you've opened that door like that student opened it for me. If the person's like, nah, blacks get this and whites get that and we're done, then you can say, oh, thank you very much. It's very interesting. I really appreciate your insights. And then you move away. But you can spark change with just a simple question. It was literally that one email that I got in February of 2020 that started this journey for me.
Thank you both for those answers. So now we're going to open up questions to the audience. Ashley, I saw that you have concerns about if it will ever be achievable without universal healthcare at a minimum. If you want to expand on that, really.
And I'll just say that we're out of time, and some of you have other things you need to go to. So let's just have a couple very brief questions and answers. And I think I'll hold a office hour sometime if students want to drop by and talk about some of these subjects after hearing this talk.